Essam Tarek. Essam has his main interest in intervention, so this topic is fitting his experience.
So good afternoon. So my name is Essam Abdullah. I am a lecturer of radio diagnosis and intervention radiology at Ain Shams University Hospitals. So welcome to this presentation today. As over this next 15 minutes, we are going to understand more for conventional ultrasound and contrast enhanced ultrasound. As all of you know that the ultrasound now, it's evolving modality of imaging that we can rely on in the treatment and management as well after the diagnosis of the lung lesions. So for the introduction, first of all, the understanding of the lung ultrasound, contrast and conventional and contrast ultrasound with contrast enhanced ultrasound in the lung lesions are now evolving. Also, after this finish the presentation, we will find a review the normal and pathological pattern in conventional and contrast enhanced ultrasound with exploration the application and clinical needs for this modality. So lung ultrasound has grown into an essential imaging technique. Contrast enhanced ultrasound further improve accuracy, especially for peripheral lung disease. And here's one of the challenges of ultrasound, which is the difference of accuracy impedance between the air and the lung tissue, which is given different to characterize the central or mediastinal lesions. So mainly we are concentrate on a peripheral lung lesions that will particularly valuable during COVID-19 especially. So if you remember that what happened during COVID, most of us as a clinician or a radiologist rush to do a CT exam before to diagnose the patient or even to triage the patients, which is rely on and take us to a lot of unindicated CT scan, and we expose a lot of exposure of the dose of the patient, which is not the real case. So that's why we trying to figure out if there is another modality that we can rely on. So from that, the ultrasound, either conventional or contrast, start to evolve at that time. So the lung ultrasound itself, it's provide and improve imaging diagnostic detection, making for patient with a possible peripheral lung disease because of it's feasible, easy, with no ionized radiation so far. Again, some challenge that we feed either in conventional ultrasound, as we say, the difference in acoustic impedance between the air and the lung tissue, also the availability of the contrast media. Unfortunately, for now, I'm talking not globally, I'm talking especially for Egypt, the contrast media that we are using in a contrast enhanced ultrasound, especially in lung, it's not that globally available. Still it's available in Egypt, in some hospitals, but it's not globally, so that's why we need to investigate more for such a reason. Also, we are asked, as we have a doctor of chest here, we are asked for the clinician to be utilized this system for a clinician adoption, this is from your end of view, from our end of view, we have to more training and more experience on these topics. Let's just remind you with a normal conventional ultrasound technique. As you said that normally we want previously the ultrasound request mainly for a specific or a localized lesion. But now we can doing as a general or examination, so we'll start to subdivide the chest to 4 quadrant or 6 segment, and then every segment I have to examine in longitudinal and transverse projections to ensure that I'm doing a high scope for all these segments. The probe that I'm using, most of the time we are using the curvilinear probe for more anatomical detection, for more specific and details, why then we can go for the transducer or the linear one. It's more superficial, giving us more ideas. For sake of the time, I'm not going to mention the whole artifacts for the lung, but unlike many of the imaging technique, lung ultrasound mainly detect the artifacts, not the normal anatomy. And we have two main artifacts, which the A-line, I don't know if it's here, I think then you cannot see my cursor, okay. So we have the A-line, which is in horizontal lines, that means, actually this is the reflection of the air and the pleura. So as you can see, we have a multiple lines, which is horizontal line. All this is a normal, it's A line, mean there is an air inside the lung. So it's the normal finding, or maybe in a pneumothorax we have a lot of air, so that also will be found as an A line. The second artifact also which is important is the B line. So in contrast of A line, the B line actually is a longitudinal line. The physiology for behind this B lines is not incompletely understood, but now mainly it's between the, again, acoustic impedance between the fluid and the air or the lung tissue. So when we have normally, we have some fluid inside the lung, so normally we will find the B line. Most of radiologists say that, okay, the cut number will be 3, so if we, thank you so much. So as you can see here, we have 3 longitudinal line, which is the normal. So if we have, most of radiologists say that the cut line is 3. So if we have 3 or less, this is normal finding. If we have more, then we have to go to subdivide. Either it's localized or diffuse. If more than these 3 lines or B lines is localized, then we are for localized fluid collection, either encysted empyema, encysted diffusion, whatever. But if it's diffused, then I'm going to think for more diffuse pathology, like interstitial edema or ARDS. Jumping to the contrast enhanced, it's the same steps for a conventional one. Patient position, and here is the gold standard for ultrasound, which is the position of the patients, which is more, I will find the comfortable position of the patient, regardless he's sitting position, lying down, or even standing, I can do the examination. And this is in contrast of the CT, which is the patient should be lie into the CT if he anesthesics, under general anesthesia or whatever, but here I can do it just comfortable position of the patients. Then I will go with the B mode, which is the conventional. Then the next step will be administration of contrast media. So the contrast media we are usually use, it's the SonoView, which is a sulf-hexa fluoride material, which is a micro bubble. So this micro bubble, it's just a gas, so it just go to the microvasculature, will be inhaled and exhaled by the lung. So if we have a patient with impaired renal function, I think this is a very good substitution to do on contrast CT. But it's only depend about the availability of this contrast again. Then the most important thing is to go continuous recording, because it's contrast enhanced. So I have 4 definition, which is very important here. So we have what we call the time of the enhancement. So actually time of the enhancement, it's referred to the time when earliest the bubble, which is the contrast, enhancement appeared to the lesion. Therefore, assessing the time of the enhancement, it's crucial to determine whether the tumor is vascularized by a systemic or pulmonary circulation. Here is another basic of contrast enhanced. It's depend about that, the fact the lung has a dual blood supply. We have a systemic blood supply with the bronchial, mainly for enriching the lungs parenchyma with the blood. And we have the pulmonary circulation, which is mainly for gas exchange. And here's also the time of the enhancement depend which is the lesion supply, because the pulmonary circulation is more fast, so there is another cut number here, which is the 6 seconds. So if the lesion start to enhance on 6 seconds or less, mainly this is because it's enhanced by or supplied by a pulmonary circulation. If it's more than 6 seconds, that means it's more systemic circulation. Another definition, which is enhancement intensity. So actually the enhancement intensity, it's referred to the degree of the enhancement, either marked, moderate, or absent. This is a very subjective to your eye, and it will come with experience. Enhancement pattern, as any contrast enhancement study, we have 2 enhancement patterns, either homogeneous, which will raise the benign the lesion, more of the benign lesion, or we have the heterogeneous with mainly with a malignant lesion. And finally, the time of washout. So actually, this is the time elapsed from contrast agent administration till the contrast start to wash out. So early washout is defined within 60 seconds. So now again, we have two numbers which are very important, 6 seconds and 60 seconds. So 6 seconds, it's the yearly enhancement with a pulmonary blood supply. More than 6 seconds, that is late enhancement with a bronchial blood supply. The 60 seconds, which is the washout. So if it's below 60 seconds, that means early washout. After 60 seconds, that's mean delayed washout. And this is very important to how we going to interpret and differentiate between the anatomical and pathological lesions. Here's some examples for the stomach pathological lesion that we can find using the contrast-enhanced ultrasound. First of all, we have atelectasis. As you can see here, so most of these images taken after the contrast. So if you can see here, the arrow, we have early homogeneous enhancement within less than 60 seconds, and we look in the delayed after 100 seconds, still we have homogeneous enhancement. So there is no washout. So in atelectasis, we have early homogeneous enhancement with no washout. And this will be differentiate between the atelectasia and pneumonia, we're going to say in the next slide. Also here we have the pulmonary infarction. So for pulmonary infarction, it's infarcted part, so no vascularization, so for sure there is no enhancement, and for sure there is no washout. For pneumonia, still we have early enhancement, but we have delayed washout, so it's more than 60 seconds. There will be a washout in comparison to the atelectasia where there is no washout. Both has an enhancement early, but one will have a delayed washout, which is the pneumonia, and one will know there is no washout, which is the atelectasia. For the malignancy, as any contrast-enhanced study with a malignancy, we have early washout with a early homogeneous enhancement. For the abscess, still we have abscess or empyema, like an abscess ring enhancement. We have a peripheral enhancement, either the center will not enhance. Again, for the sake of the time, I'm going to just mention the application of the lung contrast-enhanced ultrasound. So actually I personally prefer to categorize the application to two big categories. First of all, something that we're going to diagnose, as we mentioned, pneumonia, pulmonary infarction, atelectasia. It's also help us to differentiate between benign and malignant lesion. As any contrast material, the benign will be smooth without investigation, without invasion of the chest wall. Either the malignant will be irregular wall, and the border will be invasion of the chest wall. Plus the enhancement pattern we mentioned previously. The therapeutic one or intervention benefit or application, it's to ensure 100% this lesion is viable. So most of the time when we take a biopsy, needle CT guided or ultrasound guided biopsy, around 10%, 20% of the cases, they take, the pathology, from the pathology said, okay, you take necrotic tissue. So when we have something he can use an ultrasound that can validate this lesion, it's a viable, it's not a necrotic. I think it will increase the diagnostic and interventional procedure and increase the accuracy of our biopsy. Also to make, if this lesion is highly vascular, so I try to be more cautious because of the post-biopsy bleeding or hematoma. This is again, how can we differentiate between the benign and malignant very fast. As any contrast enhanced modality, the benign will be a regular smooth wall, there is no enhancement, there is no structural invasion, and there is no metastasis for sure. To sum up again, how can we differentiate between the atelectasia and between the pulmonary infarction? It's all depend about the enhancement pattern and the four main parameters that we are used before. For the conclusion, the lung ultrasound now is essential bedside diagnostic tools, particularly for peripheral lung disease. Contrast-enhanced ultrasound extend the role by improving diagnostic accuracy and guiding biopsy safely. It cost effectiveness and probability make the valuable complement with the CT and X-ray. Thank you so much.
شكرا يا عصام. دلوقتي هتبقى آخر محاضرة إن شاء الله معانا دكتور يوسف. post sternotomy imaging